All right, folks, we'll give people another minute or two to join. All right, let's get started. Welcome everyone to the CHIP Landmark Ideas series. Today, we're going to hear from Mollyann Brodie, who is the Executive Vice President and Chief Operating Officer at the Kaiser Family Foundation, as well as the Executive Director of Public Opinion and Survey Research. We're going to hear about the value of small data in a big data world, why representative public opinion polls and surveys are still an important tool for our understanding. I'm Ken Mandel. I direct the Computational Health Informatics program at Boston Children's Hospital. We are a 30-year-old program founded in 1994. We are a multidisciplinary applied research and education program located within Boston Children's Hospital and affiliated with Harvard Medical School. You can learn more about us at chip.org, and this is the Landmark Ideas Series event featuring thought leaders across healthcare, informatics, IT, big science, innovation, and more. Today, polling. I'm going to briefly introduce Dr. Brodie. We're going to have the presentation. I'm going to ask you to put your questions in the Zoom Q&A box as we go. Then we'll have a few closing remarks. So Dr. Mollyann Brodie focuses her research on understanding the American public's views and knowledge concerning health policy issues and the role of opinion in health policy debates. Her research has been published in the Journal of the American Medical Association, New England Journal of Medicine, Journal of Health Politics, Policy and Law and Health Affairs. She's co-editor of the book, American Public Opinion and Healthcare. Even if you don't know her name, you have certainly seen her work because the Kaiser Family Foundation is the intel inside of all the polling data that you see or a lot of the polling data that you see in mainstream media publications informing you about what Americans think about key issues. So I'm going to pause there, and I will turn it over to Mollyann.
Hi, thank you. I'm really very excited to be here. I'm going to share my screen and get set up and make sure everybody can see that. So Ken, if you can give me a thumbs up that it's all good, great. Great. Well, I was really excited to be asked to do this, especially as I started watching some of the past sessions that you've had. You've really had some outstanding, some groundbreaking speakers. And as I was thinking about some of the topics you've covered in the past and the overall focus of the Computational Health Informatics program, it really helped me think about the set of materials that I wanted to share with you today. What I'm hoping is that at the end, you will really consider my suggestion that representative public opinion surveys are still an important tool for our understanding, even in the face of all the very exciting new AI, web scraping, and other big data tools that I know most of you spend your time working on. Now, I know this is an election year, and polling people are the least popular and most criticized for the endless horse race polls. You've probably already seen way more than you want to see. You're going to see a lot more in the coming months. And I would agree with that. I would agree that polls and surveys actually are so much more, and they're so much more valuable and useful than just trying to predict who's going to end up winning the White House or congressional seat. Because honestly, you don't need polling for that. You can just wait till the votes are counted, and then we can find out who wins. So I'm going to make the case today for why polling, I think, is more valuable for a lot of other reasons, not necessarily for horse race polling. Okay, let's see. There we go. Okay. So before I get started, I just want to make sure you know who KFF is. We are a nonprofit information organization that focuses on national health issues. We're basically a unique combination of a 3-in-1 organization. So we have a big policy analysis and research team, a big polling and survey research team, and then we do health policy journalism. You may see that in your inbox as well. We also do some other things like run big public health information campaigns. But at the end of the day, our focus is to be the unbiased, nonpartisan analysis, produce the basic facts, be the honest broker, basically, in policy debates. I do think that the one thing that makes us, particularly us, like what's really different about our DNA, is our laser focus on people, how the latest health policy option or the latest healthcare institution is affecting people. What about access and financing of care? What does it mean for people in their daily lives? And that's sort of the core principle that we organize all our work around. Our audience is national and state policymakers, journalists, the health policy community, and the public at large. So here is the question that I pose for today. In a world where AI and meta large data sets can be mined for insights in healthcare decision making, what is the purpose, the benefit, maybe even the opportunity for small data? That is representative public opinion surveys with observation numbers in the thousands, not in the millions or billions. What can we learn from public opinion surveys that we might not be able to learn another way? Now, my definition of small data and most of the survey data that I'm going to talk about today comes from representative, probability-based surveys with samples that have about 1,200 to 1,500 respondents. Sometimes we'll have projects that have 3,000 to 6,000 respondents. That's a big project for us. But I'm assuming that in a computational world, those data set sizes would be considered quite small. That's what we're going to talk about today. So I want to start by just sharing why we at KFF spend so much time, so much effort, and so much resources on polling and survey research. When you think about the policy environment and policy debates, in the first and most primary case, we believe that the public's views and their experiences are important to include in those debates and decisions. So our primary reason for public opinion polls and surveys is to make sure that we can amplify the public's voice in the system, especially for those groups who don't often have a seat around the decision-making table. This means that we make sure our samples and our methods allow us to present representative data for subgroups, for example, for historically marginalized groups in our society, those who are particularly disadvantaged or in need of our healthcare system, like the uninsured, chronically ill, those with serious conditions. Having representative data from these groups that we can drill down even further into further categories also serves on a check on what I will call the, quote unquote, conventional wisdom. That is, I don't know if you've ever seen it. I have certainly seen it in my career where you'll see a policy proposal by anecdote because somebody knew somebody who had this problem, or you'll see a journalist story that's reporting by anecdote. Or you'll see sometimes policymakers or journalists make assumptions or hold biases when they're thinking about groups, especially when they think about groups in a really monolithic way. So I think our data really helps prevent against that and shed light to help make sure they can do that better. The second big reason we do it is in a $4 trillion industry, we want to make sure that there's an independent, unbiased source of information that's in the public domain and on the public record. We believe that there's a need for information that can shed light on the claims and arguments that are made by the vast number of moneyed special interests in our healthcare system. In most cases, those moneyed interests do all the sorts of research that I'm talking about, and they do it to figure out how they can best sell their positions to policymakers or to the media. We just believe that everyone should have access to that information as well. And then another principle that really guides our work is that in contrast to most of the media polls or those conducted by advocacy groups, we try to pay special attention to information about the public's experiences and perceptions and their knowledge of policy and the relationship between all of these different types of information. In many cases, it is that relationship between lack of knowledge and their behaviors or their opinions that can really provide the most important insights. And then the last thing is, we believe that our data can show where leadership is necessary and where public education challenges exist. Uh, Public opinion surveys can tell you where the audience is, and it can provide that context for how your efforts might need to be adjusted based on how communities or how people are currently perceiving the situation. In a sense, it helps leaders be leaders. With all that said, it's not that we think that you should follow the public, that the public is right in terms of picking the right policies, right? Public opinion surveys will tell us where they are, but they don't necessarily tell us if that's really the right policy to be implemented. We don't assume the public is right, but it is, I think, incredibly valuable to know where they are, understand what they are experiencing, and to feed that back to help leaders, advocates, the medias, and the policymakers do a better job. So that's basically our case for why we do this work. I've already made a big sort of emphasis on representativeness, and I'm going to do that throughout. And we could talk, and certainly in the Q&A, I'm happy to talk about this, about the various biases in data sources and collected. And there's all sorts of different biases, and there's all sorts of different gaps in data, depending on how it's collected, depending on what the source is. But if at the end of the day, you really do care about how policy is affecting all people, or if you're seeking to understand distributional effects or discrepancies in gaps or inequities, we really do have to pay a great deal of attention to whether our data is representative, and if so, of what. And so that's going to be a big word I'm going to use a lot today. I'm just going to point out this one example, right? So in terms of data that's collected just over the internet, it might be surprising at this day and age, but there's still 7% of US adults who tell us they never use the internet. And that group isn't, distributed randomly across our population. It is 1 in 4 adults over age 65. It's 1 in 7 lower income adults, adults with high school education or less, 1 in 10 rural adults. So these offline adults are among the groups that are often most impacted by policy decisions for public programs like Medicare, Medicaid, Social Security, a lot of things that we spend our time studying. Their voices are going to be missing from the public discussions if we're only looking or scraping or thinking about what's being said or communicated through sort of internet mechanism. So again, just one small example. Okay. So for the rest of our time together, I'm going to walk through 3 case studies of public opinion surveys where I think that what we learned from our representative data played a really important role, either by itself or in conjunction with other data sources at the time. And what I think they did is in each case, I think they really helped to illuminate an important policy situation and helped inform particular decision makers in our system. And I'll point that out as we go through each case study. But first, I just wanted to share sort of an overview of the scope and methods of all of our work. We do a lot of different types of surveys. We do monthly tracking surveys. Those are surveys, again, in the small size of 1,200, 1,500 respondents, randomly selected every month to keep track of various topics that are on the agenda. We also do projects that are special topic surveys, things where we'll do design a whole survey around a topic, like around health misinformation or consumer experiences with their health insurance. People's experience and views of mental health policy. Did a project on data privacy at one point, which is how I actually met Ken. We do surveys where we're really focused on specific populations. That is, going to do a survey we just did of 3,000 immigrants in the US to try to shed light on what's happening to immigrants and their healthcare experiences, their experiences beyond healthcare. We did a project I'm going to talk about later today about a random sample of trans adults. We've done projects of the uninsured, those who experienced Medicaid. So we'll do certain surveys that are very focused on a population that we want to learn more about for some reason. All of our projects, we end up using probability-based samples as our means, again, because of our commitment to representativeness. We'll do things in as many languages as we need to do, again, trying to make sure that we're representative of whatever group we're really talking to. We're also very committed to transparency, and we can talk more about that if you're, well, let's talk about that in the discussion, why I think that's so important. Okay, my first case study. So I want to start us off talking about the policy and politics surveys around the Affordable Care Act. I assume many of you remember this policy debate and the subsequent implementation of the law. It dominated healthcare headlines for more than a decade. It is coming back now as candidate President Trump is raising issues around the ACA again. A lot of our survey work over the course of that decade was dedicated to understanding public attitudes. The main vehicle we used was our tracking survey. Again, we did monthly surveys of about 1,200 to 1,500 respondents, 102 separate surveys over that time period. So in total, we had about 130,000 respondents, which in my world starts seeming like big data. But each individual project was small data. I'm not going to be able to go through everything that we found and learned during that project. But I do want to share some of the insights that I think can shed light on how major policy issues like the ACA is being, like the ACA, how surveys can shed light on a policy issue like this. Overall, over the course of all of those surveys, we came to sort of some broad conclusions. Opinions on the law were largely stable and divided. I'm going to talk about that more in a second. Can never overestimate the effect of partisanship and that impact on views and experiences with this law. It got to be that by the end of the debate, 2022, 2023, if I have a data set and I know a respondent's party ID, I can pretty much predict what their attitudes will be on a variety of questions regarding the ACA. We found that most of the provisions within the ACA were actually quite popular. Except, of course, the individual mandate, which, as many of you may remember, that provision went away as a result of one of the Supreme Court cases. That there was remaining confusion, misperceptions, and enormous amount of lack of knowledge when it came to the ACA that persists even today and has implications for people's ability to use and get the most benefit out of the law. And lastly, in the wake of the repeal effort that happened in 2026, 2027, the Trump administration, turns out the ACA became more popular, but still divided. So I'm just going to walk through a couple of these to draw some broader conclusions. So we asked this question, do you have a generally favorable or generally unfavorable view of the 2010 healthcare reform law? On virtually every questionnaire that we did over that decade, and we're actually still doing it today. You can see here that there's certainly a lot of ups and downs and some noise in this data, but the blue line is the share who has a favorable opinion, the orange line is the share that has an unfavorable opinion, and the gray line is the share that has no opinion, or they didn't want to tell us an opinion. And basically, if you take a step back, we have, it was pretty stable and pretty divided across the whole time frame. We basically have three horizontal lines. There are some reactions to certain events at certain points in time. There's two periods of time where one side, the favorables or the unfavorables, maintained a gap ahead of the other side. So for example, from late 2013 through 2014, you'll see there, following the botched rollout of healthcare.gov, there was a sustained period where the unfavorables outranked the favorables. And then secondly, in this current period, which I just mentioned, which is the period since the ACA repeal debate happened, where now the favorables outrank the unfavorables, really as a result of the rallying around the ACA when the threat of repeal became real. The bottom line is this is pretty much the picture of people's views of this law, even though we've had a lot of really dramatic political moments, including two Supreme Court decisions. This chart, I think, helps you understand why opinion has remained so stable and so divided. The partisan divide started early, and it didn't abate over time, and it persists today. So this is the share of each partisan group who has a favorable view of the law. The Democrats are the blue way on top, the independents are the gray in the middle, the Republicans are the red. At the very beginning, as you may have remembered, this law was passed by Congress on a straight partisan vote in 2010. And despite many expert views, including my own, that over time the law would become more popular and less politicized as people started to receive their own health benefits, and the fears that the opponents had raised started to go away, during that debate, that never materialized. This polarization started at the beginning and it stays through to this day. As of May of 2023, 9 in 10 Democrats still have a favorable view. 73% of Republicans have an unfavorable view of the law. Now, this partisanship also impacts how people view their own experience with the law. So when we ask people if they think the law has generally helped or hurt them and their family, Democrats tell us it's generally helped. Republicans tell us it's generally hurt. Now, I can attest that there was actually nothing in the law that explicitly told doctors or providers, treat Republicans differently than you treat Democrats. It's just that people's perceptions really got set early on about what was going to happen to them. And people, Democrats gave credit to things that happened to them in the healthcare system to the law, whereas Republicans continue to blame the law for anything that happens to them in their healthcare experiences. Now, I want to make 2 points with this chart. This chart is as many of the individual provisions that were asked that were in the ACA, and it shows you the share who had a favorable view of those provisions. So by going beyond just the top level favor and oppose, we were really, I think, helping policymakers, candidates, and the media understand more of the nuanced reaction of the law. So while overall, Republicans in particular had an unfavorable view of the law when we just asked about the ACA or when we called it Obamacare, and we can talk about question wording in Q&A if you want. We found for early on, and it continues today, that many of the individual components in the law are quite popular on a bipartisan basis. So large majorities like all the things that are in the law. They like the extended dependent coverage for age 26. They like that it created insurance exchanges. They like that it prohibited cost sharing for preventative services. They particularly like that it prevented coverage denials from pre-existing conditions. So the second point I want to make with this is that this is the sort of data that really did help advocates, candidates, and the Democrats, I think, avoid the ultimate repeal of the law. They knew that there were lots of parts of the law that were popular, and it's one of the reasons that the Republicans in Congress have had so much trouble fulfilling their continued campaign promise to repeal and replace the ACA, because it's really hard to take away something from somebody once they've had it and like it. In fact, about 47% of the public, so almost half of the public, had told us that they or somebody in their household had a pre-existing health condition. So losing those protections was something that scared a large number of people, a large number of voters. Majorities of Democrats, Independents, and Republicans kept telling us that keeping those provisions were really popular. This is a set of data on this slide where we asked people about the provisions that were in the ACA replacement plans. And you can see there's some things that were in the ACA replacement plans that the public supported, but the things that they were most concerned about and they most expressed their opposition to were getting rid of the pre-existing protections. And this, in fact, became an impact to the electoral politics for the 2018 midterm election. Election observers noted that in many close races, the support continuing the pre-existing condition protections was likely the difference between the congressional vote, and it likely pushed Democrats over the edge in taking control of the House that year. So in this first case study, I was just trying to illustrate that by tracking views of a law over time, we can provide a big picture view and reactions to key political events. We're able to look at what's behind people's views and what they think about with various components of the law and how that might change when people are presented with arguments for and against the law. We showed how advocates, policymakers, we were able to show advocates and policymakers what people's fears were with repeal. And it really showed gaps in awareness. I didn't actually show you this data, But the lack of information really did contribute to people's views of the law, but it also contributed to people not being able to get all the services that they could have gotten out of the law. And then lastly, we of course documented people's experiences. Okay, want to move on to a more recent case example, and this has to do with probably what happened to all of us in March of 2020, March of 2020. When the pandemic hit, like everyone else, we pivoted our work. Besides shutting down our offices and shifting everyone to remote work, like many of you probably had to do, we started adjusting our surveys by adding questions focused on the ways that the pandemic was affecting people's lives. Now, we knew that this was going to change quickly over time, and we set out to track that dynamic nature of opinion and experiences, particularly with the vaccines. We wanted to understand things like confidence in the vaccines and people's intentions to get vaccinated or not. Who did they trust for information, and what messages would resonate? And also, where were they getting their information or their misinformation on the topic? This is the methods we used for the project. Again, we can talk more about those if anybody cares, but we were particularly concerned about representation, particularly for Black and Hispanic adults, because we knew already that there was going to be a disproportional impact on people of color, and we wanted to make sure we had large enough subgroups to be able to track that and shed light on it throughout our data collection and our distribution of the findings. So here's just the main trend question on vaccine uptake. We asked the question about whether you wanted to basically did you want to get the vaccine as soon as possible? Do you want to wait and see? We're only going to get it if you're required, or definitely not. So you can see this is over time. And as the vaccine rollout happened in January of 2021, we quickly started moving from the as soon as possible people in the royal blue. They started getting vaccinated in the dark blue, right? And you can also see how not quite as quickly, but ultimately the vast majority of the people in the wait and see category converted to getting the vaccine over time. What I think is very remarkable is the stability of the size of that dark green group. This was the share that would say they would definitely not get vaccinated. So what it meant is that as more and more people got vaccinated each and every month, the remaining unvaccinated share was increasingly made up of those who were most resistant to get vaccinated. And that was important to help the people on the ground who were trying to increase vaccination rates understand that their population was changing and the dynamic and their messages needed to change over time. Now, you might ask, and it's a really legitimate question, with the CDC was tracking vaccinations in this, by collecting the data that the state public health departments were collecting. So why would we need to be tracking vaccinations in this way? What was our added value to the administrative data? Well, there are a couple reasons why we thought, a couple reasons it turned out to be valuable, and a couple reasons why we planned on it for being valuable. So one of the reasons that it turned out to be valuable is this first one. Early on, I should just start with this chart shows is our data, which is where the squares are, another set of survey data, which is the big round dots, and then the CDC data, which is the smaller round dots. And you can see early on in the pandemic that we were really pleased with how self-reported vaccination rates in our surveys matched up with what the CDC was reporting in their tracking and collecting straight from the state health departments. We were initially concerned that we might get over-reported data because of social desirability bias, which is certainly something you do have to worry about with self-reports. However, we didn't see that problem, especially not early on. But later, in 2021, when we started getting into the boosters and counting the boosters, we noticed that the CDC numbers were climbing faster than our numbers. And we started wondering if we were getting underreporting in our surveys. We had, certainly been tracking the increasing politicalization of COVID, and we're going to talk more about that in a minute. But we thought that many Republicans might not wanted to admit to us later on that they were vaccinated, since it was out of step with their own political identity. But what actually turned out is at the same time, the CDC publicly acknowledged that their estimates they were actually overestimating the share of people who had gotten one dose and underestimating the share who had gotten a booster because their doses couldn't distinguish. They weren't linking in the data between the doses and the boosters. So the point here is that data like ours, small data, can, in this case, and in some cases, be really important for filling holes where the administrative data might be problematic. And it shed light for those who are working on vaccination campaigns. Now, in another way where we knew that we thought that the administrative data would be lacking was we knew that many of the states were not going to be reporting vaccination data by race and ethnicity. And so with our data, we knew that we could be showing who was getting vaccinated. So in some of the very early work we did at the beginning of the pandemic, I think many of you may have seen this in your own data, we knew that people of color were likely going to be more hesitant to get vaccinated. And we certainly saw that playing out in our survey results. So in April and May, you can see here that we saw higher shares of white adults compared to Black and Hispanic adults saying they had gotten the COVID-19 vaccine. So the white is that light blue, the dark blue is the Black adult responses, and the royal blue is the Hispanic adult responses. So understanding this in itself was certainly important, right? Not every state was collecting this kind of data, and it really helped confirm that there was a gap in vaccine uptake. But probably what was more helpful and how we expected our surveys to be more helpful was that we were going beyond just identifying these gaps, but we were also going to be trying to learn things in the surveys that could help identify the best way to address and potentially close those gaps. So, for example, we could tell people, and we were able to learn that the profile of the unvaccinated Black adults and the unvaccinated Hispanic adults was somewhat different. Unvaccinated Black adults were more likely to say that they wanted to wait and see before they got vaccinated, suggesting that they might lack confidence or trust in the vaccine, or they were waiting for more information, which is certainly what we learned from their follow-up questions. On the other hand, unvaxxed Hispanic adults were more likely to say they wanted to get vaxxed right away, suggesting that their lower rates of uptake were more likely because they were facing access barriers to getting vaccinated. Again, something that was later proven to be true in some of our data. So we certainly heard about their concerns about missing work, that they were worried they were going to have to pay more out of pocket. They were concerned they weren't going to be able to get it at a place they trust. But in addition, and I told you at the beginning that we like to try to make sure we can dig down within these populations so that we're not thinking about these populations in one monolithic group. We were able to do some very extra large samples of Hispanics that allowed us to look at the differing experiences based on things like immigration status, and found that people who are not citizens faced additional concerns and barriers, including worries about having to provide government identification to get vaccinated, and fears that they might be negatively affect their own family members' immigration status if they did seek out a vaccine. The bottom line is that we fed all these findings into the hands of the advocates, the CDC, the White House, the people who are doing outreach and campaigns like the Ad Council, people on the ground, to help close these gaps in real time and to help the message campaigns in real time. Now, we also, like the partisan polarization on the ACA, we saw deep polarization about the COVID vaccines. This was probably the clear and most glaring example that I've ever seen in public health, where partisan identity politics has impacted public health behaviors. And it's also probably the case where it's going to have the most lasting impacts on vaccination rates across the board. What you see here is the trend in the share who said they were vaccinated by political party. The dark colors are the share who got vaccinated. The greens are, I'm definitely not going to get it. The dark blue is the Democrats, the royal blue is independents, the light blue is Republicans. You can see at every point in time, there are fewer Republicans than Democrats who got vaccinated. Alternatively, even today, about a third, the 32% of Republicans are telling us that they'll definitely never get a vaccination compared to 8% of Democrats. And what we were able to do with all this information, the demographic profiles, the attitudinal questions, and their experience-based questions, is create sort of segmentations of the unvaccinated population to really help the people on the ground figure out messages that might work. we really initially segmented them out into wait and see and the definitely not. You can see that they're very different by demographic group. They're also very different by attitudinal measures. So the wait and see group were worried about getting sick from COVID, whereas the definitely not group was never worried about getting sick from COVID. In fact, 3/4 of the definitely not told us that the vaccine was a bigger risk to their health than getting COVID was, whereas the wait and see groups basically said the opposite. The refusers, the definitely not groups, felt that the seriousness of the pandemic had been exaggerated. That was certainly a talking point we heard from President Trump, and that continues to be a really big predictor of willingness to get vaccine and boosters even today. And I didn't show it here, but we look closely at misinformation on COVID vaccines. And, you might remember Invictin, you might remember some other things. We asked about all those. The relationships between wait and see and definitely not, and the relationships between the political polarizations were persistent in all those cases as well. So what that meant is that we could therefore then start testing what messages falling in line with these attitudes could be most effective for these different groups. Here's just some of examples of the things we did. So for example, we found a variety of messages that might be effective for the wait and see group, including emphasizing the effectiveness of the vaccines at preventing hospitalization, that even though the vaccines themselves were new, scientists had been working on the technology for 20 years. These are things that may start impacting people's views. And we were able, again, to feed that into the process. The other way we were able to shed light on the actual messages and the best strategies for changing vaccination status was based on a series of surveys we did where we talked to the same people at 2 points in time. And I was going to finish up this case study with this. So we asked everybody, we asked a sample of people in January, what did they expect to do? Were they going to get it right away? Were they going to wait and see? Were they going to only if required? Or were they going to definitely not? We called them all back 6 months later in June. And we asked them, what'd you do? Did you get it? Did you not get it? And if they had been a switcher, why? And so you can see here that the vast majority of people were pretty good at predicting their behavior. 92% of the people who said, I'm going to get that thing as soon as I can, got it within 6 months. The wait and see group is a little bit more divided, but half of them had gotten it within 6 months. The people who didn't expect to get it, the vast majority of them didn't, right? 51% didn't get it. They still were in those same categories. But what's most interesting and what was most valuable here was the 24%, those switchers of that group. We followed up with that group and we asked them in a bunch of open-ended questions to tell us what changed their mind, what persuaded them, what made them get that vaccine. And what stood out was really the influence of personal interactions with doctors and family and friends. And also many people just said they bugged me, or I found out that my friends got it and the side effects weren't so bad. So all of this data was fed back into the system. We fed these barriers there that people reported, the fears people reported, the misinformation people reported into all of the groups on the ground so they could use that information to try to make a difference in the share of people who got vaccinated. This was just an effort we did for ourselves called The Conversation, which we can talk about later. All right. My last case study, and I wanted to do this because this is an example where we really just focused on one population. We do this a lot. I told you we've done it with immigrants. We've done it with college students to shed light on the tough issue of sexual assault on college campuses. We've done surveys of long-term opioid users to shed light on the relationship between prescription painkillers and opioid use. We've done all sorts of very complicated samples. We could talk about the challenge of reaching these samples. But I wanted to talk about the survey we did on representing self-identified trans adults. Now, trans people are a group that makes up less than 1% of the US adult population, but they're also a group that experience disproportionate stigma, systemic inequality, discrimination, and harassment in many areas of their lives. But due to their relatively small share among an adult population, most national surveys never have enough of a sample size to accurately report on their attitudes or their experiences. You couple that with what we've all seen in the news in the last couple of years, the influx of anti-LGBTQ bills introduced and passed at state legislators, and the increase in violent attacks among these groups across the nation. In fact, in 2023, the Human Rights Campaign declared the national state of emergency for this population. And so we and our long-term partners at the Washington Post felt like we could shed some light on this and amplify the real-life experiences of this group. And I note again, this is a real small data set. If 515 self-identified trans adults, very carefully selected, very careful about their screener, and with really difficult methods to even get 515. But here's what we learned. The way our partnership works with the Washington Post is we jointly pick the topics and we design the survey. KFF team usually leads in the analysis and works with the reporters directly on the stories. But at the end of the day, they have editorial control over their own stories, and we write a comprehensive report. Here you can see a smattering of the headlines from the more than 12 stories that they published. These headlines, I think, give you a flavor of the depth and the breadth of the survey. Included, we tackled how and when trans adults recognize their trans identity, how that evolved over time, a deep dive on their childhood and the assessment of their life today, as well as trying to capture their experiences with discrimination, mistreatment, and challenges accessing healthcare. I'm just going to run through some of the key findings, particularly the findings that I think shed light on some of the mistaken assumptions that many cisgender people have about trans people, and the ones that I think best inform some of the political and policy conversations that we're seeing across the nation today. So first off, you see here on the left that 2/3 of trans people say that they began to understand their gender was different from the sex they were assigned at birth before they turned 18. In fact, 1/3 said they did before they were 10 years old. And on the right, notice that most trans adults want to describe themselves as non-binary or gender non-conforming. Very few use the terms trans men or trans woman, which is that binary distinction that so many cisgender people want to put on them. I think this was probably one of the most powerful and most important charts. It shows you the ways that trans people wanted to go about their transitioning. And it suggests that transitioning differs really widely among trans adults, and not all trans adults feel that they need to transition in any one way, or do they seek the same types of gender affirming care. Most trans adults reported transitioning socially. That is, they made changes to their physical appearance, their hairstyle, their pronouns, or the name on a birth certificate to better fit their gender identity. Few trans adults reported using medical approaches like hormone treatment, or having undergone gender affirming surgery to change their physical appearance. Those are certainly the transitioning types that are dominating the news headlines and the stories about trans adults in the mainstream news. Furthermore, as one of the headlines above showed, and probably most upsetting, was the gut-wrenching findings about growing up and attending school, and basically what a nightmare it was for many trans and non-binary kids. Overall, trans adults reported more difficulties in childhood than their cisgender counterparts. And you see here that large share of trans adults reported adverse mental health experiences during childhood, including mental health problems, alcohol or drug use, homelessness. 1 in 4 trans adults said they attended a religious service as a child or teenager that tried to change their sexual orientation or identity, and 1 in 10 said they attended some conversion therapy. Discrimination was almost ubiquitous. 6 in 10 said they had been discriminated against because of their trans identity. Verbal attacks were the most commonly reported experience, but 1 in 4 trans adults said they had been physically attacked because of their gender. That share rose to 3 in 10 among trans people of color. And trans adults reported some significant discrimination and struggles within the healthcare world. Half of trans adults said the healthcare providers they had come in contact knew not too much or nothing at all about providing care to them. Many reported significant issues accessing care, including counseling, routine health visits, or having to educate their physicians about their needs. In fact, one of the participants told us, they said they had to teach their doctor how to take care of them. And they asked the reporter who was talking to them in jest, would you expect a diabetic to have to teach their doctor how to take care of them? Why am I, as a trans person, expected to have to teach my doctor how to take care of myself? There were a couple of pieces of really good news in the project. One was that trans adults who had a trusted adult to talk to about personal issues in childhood were much less likely to report problems in childhood and more likely to report having things being generally safer for them than people who didn't have a trusted adult. And 8 in 10 trans adults told us that living as a gender different from the one that was assigned to them at birth made them more satisfied with their life. In fact, one trans survey participant told us, the worst day I had ever had as a trans person is still better than the best days I had pre-transition. So I think this sort of data where we can focus on one population really does help us give a check on conventional wisdom. It helps us also make sure that these populations that are hard to reach or small populations can get their voices heard in debates that are really affecting them. That ends sort of my tour de force through these 3 case studies. I was trying to show you, and hopefully in the discussion we can talk about it, where I think these small data sets that are done with great deal of care of choosing the respondents can really make a difference in policy debates, in election outcomes, and particularly in helping providers, advocates, our leaders serve people better. I didn't want to leave you, though, with the sense that I think this kind of data or polling is the end-all be-all, and it's the only thing we need. Polling is certainly not a panacea. It is just one source of data that I think helps shed light. It tells us where the public is, not what's right. It tells us where leadership is necessary. I already mentioned that. It also tells us where the public is at a given point in time. Opinions can be fluid. They can be influenced by events and what leaders say and do. I showed you a little bit of that with respect to the ACA debate. The technical issues in polling matter a lot. If we don't do a good job randomly selecting our samples, then we're not doing any better job shedding light on the real life experiences of those populations than any of the other data sets that might be available. And then there are also real limits to what you can ask and get out of polling data, things that I think are much better learned by scraping people's web browser experience or other things. There's, especially when you're talking about complex policy options, there's only a certain amount of things we can really expect a respondent to be able to really answer on our surveys. And then lastly, if you ever want data like this to matter, you have to get into the hands of the people who can use it in a timely basis. So I am going to stop there, and I'm very much looking forward to our conversation about this, and hopefully I've convinced some of you that small data projects are still really valuable when they're done well and right.
Thank you, Mollyann. That was terrific, and you give us a real behind the scenes look at what goes into these pollings and make a strong case for the small data. Let me ask you a question, a sort of meta question. We know that polls are often aggregated across multiple polls into meta statistics that provide perhaps with the appropriate adjustments can adjust for various biases or sampling errors, et cetera, or randomness inside of an individual poll. How does it feel, or what do you think about that being an individual poller and not a how do you see that as your polls get pulled into aggregate analyses across polls?
I think, again, it's fit for purpose, and it's fit for purpose. And do you not just do the purpose right, but are you doing the methods right? So I think there's people who are doing a really great job aggregating data and looking at sort of meta statistics and being able to draw even deeper conclusions because of it. But if you think about the millions of choices I have to make in deciding my methods and even my analysis, or even how I write my question or what my question ordering is, what my sample is, how I'm reaching my sample, and you think about how all the other polls that you're aggregating are making all those individual decisions, you have to be really thoughtful about what you're putting together. So are you putting apples and apples together, or are you putting, you know, apples and mismatched together and you're getting like junk? So I applaud it when it's done really well. And I worry about it when people just think more observations is better. Like, I never equate more observations being with better unless I know a lot more about how those observations are put together.
We face very similar issues in the meta-analysis of clinical trials for conclusions with supposedly larger sample size. Absolutely. Let me ask a question about your first case study. So you really highlighted this disconnect between what people thought about the ACA and what people thought about individual components of the ACA. And I've always had a sense that when people hear about the ACA, if they're not really up on health policy, which most Americans are not, and and the ACA is very complicated, how do you get at the fact that, you know, what do you think about even, does it, you know, when you ask about the ACA and you have a sense from these follow-up in-depth questions about, you know, dependents up to 26 or pre-existing conditions, and you see that they don't actually know what's in the ACA, but they do support those things. How does that make you think about the higher level question about what do you think about the ACA, and can you get at that in a valid way, even though it is valid because people are going to vote for candidates that say that. So it's complicated.
Yeah, and I think it's just the real value of having the nuanced opinion and us being able to say at every point in time, like, look, yes, you're seeing a divided America. Yes, they are divided on the politics of the ACA. The ACA has become a symbol. It's become a symbol of the Obama administration. If you liked Obama, you like the ACA, you like Obamacare. If you didn't like Obama, you didn't like it, you still don't like it. But that's not to say what it thinks about these particular policies and the provisions that were brought about. And I think, we like things to be simple in politics, and it's not. There is nuance. There is complexity, and I think it's, again, to me, it's one of the most valid uses for the kind of work that we do, to help make sure that policymakers, the media, and everybody who's making decisions about it knows this, so they're not just using top level data to make their decisions about where to go. And they're saying, oh, well, the public doesn't like that, so I'm going to, kill that program. Or the public says they want this, so I'm going to, give them that program. I think that's a really naive view of public policy making. I think it's a naive view of what it means to be a leader. And I think that, again, our goal is to help make sure that more people can be sophisticated in understanding where the public is on these things.
So I'll remind people to put their questions into the chat, and I'm going to now dip into the Q&A. I'm sorry, the Q&A below, down there at the bottom of your Zoom window, and I'm going to ask a few questions that have emerged. This is from Jesse Ames, who's a biostatistician. To what extent can causal inference methods, e.g. matching, weighting, graph-based approaches, be used to better inform our conclusions about survey data and consequently policy?
I think all of those things are important pieces of the puzzle. Again, fit for purpose, right? Like, if I'm trying to just tell a top line story, I might not need that. If I'm really trying to tell a causal story, then I'm going to need a lot more of those complex methods and the tools that you have to offer me. And I do think, when we talk, or when I teach a class about how you interpret public opinion data, there's a lot more nuance there, right? Like, I would say my first thing is, don't ever make a conclusion based on one data point, right? You want to see a variety of data points that are all pointing in the same direction. I want to look deeper, more at whether things are correlating in ways that make sense, whether the causality seems to be making sense. I want to make sure I understand how the weighting impacted my top line results. We spend a lot of time looking at our data weighted and unweighted, because even when you've done the most perfect job drawing a random sample, you still need to adjust to get the proportions really representative. And so I always want to see how much work are my weights doing, and that'll help me even decide how much confidence I have in my findings, or how much wiggle room I should think about when I'm comparing groups. So I think all of those things are really important as we're trying to draw conclusions. And I think it just depends again on what kind of decision are you making at what point in time, and what level of data and data analysis do you need to make that decision. I think at the end of the day, we all struggle with this every day across our day job and in everything we do in our households. Like, how much information do I need, out of what sources, and how much confidence do I need to have about that information before I make a choice, right? And so to me, it's just constantly, we're doing a series of fit for purpose conversations with ourselves.
Another methodological question from Don Goldman. The longitudinal data on ACA might be enriched using time series or statistical process control. Does the application of such a set of methods just complicate what you're trying to do, or could it be helpful?
I would say that's the same thing. It depends on what I'm trying to do, right? If I'm just trying to help policymakers overall understand the nature of what's been happening with opinion, it's a lot easier to keep it simple, right? And not have to describe a lot of complex statistical behaviors. If I'm really trying to understand in a more nuanced way the intricacies of sort of, there were some fits and starts and some movement in the ACA over time, and I want to understand, or I want to look at a very small period in that debate and talk about that, then I think these other more complicated methods would be much more helpful. For example, there's a colleague in the political science world who's basically taken my national data sets over time and used the, what is it called? It used to be called Mr. P, but he's used those using basically predicting, so that he can kind of predict at the state level the same kind of look at where did ACA views ebb and flow at state-based levels, because there was very few people tracking any of this opinion at state levels. And one of the things I think many of you know is that the Supreme Court made whether or not you expanded the Medicaid component, the Medicaid expansion part of the ACA became a state level decision, and some states expanded and some didn't expand. And it became a very big issue of what was happening to opinion at the state level like that. And so I think that some of those methods were really, really helpful for those policy conversations, because there wasn't the small data, individual data, time opinion being measured over time. So I think, again, it's great to have different methods that can be applied. And again, you apply the methods as needed for the questions you're trying to answer.
Great. And we have another question from Tim Miller, who's a AI and natural language processing focused faculty member here at CHIP. Public policy polling also seems to be a measurement of the mass media's failure to educate the public about basic facts that we would need to have the informed opinions. He says he's thinking mostly of the ACA here. Do you think your research has lessons to apply there? Is this a limitation of what's possible to measure with this kind of approach?
I think it's one of the things that we measure best. It's very easy to measure what people know and don't know, and what they think and why they think it. And I didn't, you said I had 45 minutes, would seem like forever, but when you start putting slides together, even 45 minutes goes fast. So I had a whole section using some examples, especially from the ACA. And it has been very helpful to journalists. So for example, the myth over death panel. So I don't know if any of this rings true to, if this rings a bell for many of you, but during the ACA debate, Sarah Palin in particular made a claim that the Medicare provisions in the ACA allowed Medicare to pay for death panels to decide who would get end-of-life care or not. Okay, so this death panel myth was part of the political discussion. We measured it. We measured it forever. A third of the public still believes that it's the case that there are death panels in the ACA. having data like that, or the other, actually one of my other favorite knowledge thing about the ACA is you can say what you want about whether you think it worked and achieved its goals or not. But one thing that I think is pretty hard to debate is that the ACA did change the number who are uninsured, right? The number of Americans who have health insurance is greater today than it was at the beginning. And when we ask that question, about 40% of Americans have no idea whether it's made the uninsured rate go up or down. They just don't know. So those data points, I think, have been particularly valuable for journalists who are trying to tell the stories of the lack of knowledge and of having to continue to re-educate the public, especially for editors who say, oh, we already told that story. We wrote that 3 years ago. It's like, surprise, surprise, people still don't understand that. And if they don't understand the impact of the ACA, they're not going to be able to judge it fairly and those kinds of things. So I think this question of information and particularly misinformation, both from nefarious actors and just confusing factors, basically is the greatest case facing us going forward. And I think you all in your world are probably dealing with it with the extent to which AI is going to get embedded in that conversation. We're really working at it from the other side of how can we make sure we can measure this from people? How can we try to figure out where they're hearing it? How can we try to figure out what to do about it? And it's a mass media failure, but really more than anything now with our mass media is we're just such a segmented society, and that we don't all read or see the same media anymore. Our sources of information are really, really, really divergent, and that is making this problem even worse.
And speaking of AI, are you polling around AI perceptions of AI in healthcare and other domains?
We have not done much yet. I imagine that it will come. I know there's some other folks who are looking a lot at those issues. We're, like most organizations, trying to figure out how does it affect our own work. Like, can an AI tool help us write better questionnaires? Can it help us do better analysis? I don't know. Maybe you all can tell me what I should be looking at. But I anticipate that in the next year or two, you'll see a lot of that. I think now I would look at the Pew Research Center, has always kept their eyes on science and technology. They're probably tracking that already.
Great. And final question from Platon Lukyanenko, who's a postdoctoral fellow studying AI. But he asks, is partisanship becoming an even stronger predictor of attitudes towards health policy? I mean, is this have we peaked, or is this gonna get worse?
Yeah, it's interesting. I have to say yes. I mean, in my past life, when I used to be at Harvard, where many of you are, I could list out in my talks, I could really come up with a list of things that partisans could agree on when it came to health policy. And it's getting a little bit harder and harder to do that. I mean, there's a set of things, right, that are just, people agree on the goals. They agree that healthcare should cost less. They agree people should have access to healthcare. They agree it should be easier to be able to read your bill and understand your health insurance and things like that, right? There's lots of transparency. There's lots of things that can get a lot of agreement across partisans. But when it comes to how to solve those problems, that's when the partisanship really kicks in. And there used to be more middle sort of options, and now the options are very, very technical in many cases. And so it's harder and harder for the average American to kind of understand what's being thrown out as the way forward to control costs or to control their prices or to, fix transparency. And so because of that, when it's harder to understand what the options are, they use the tools and the things they hear from their partisan leaders. So without that understanding, partisanship can actually end up mattering more. So I don't know if it's going to stay this way. But at the moment, I would say we're pretty politically polarized on a lot of ways to solve problems in healthcare. Although in healthcare, we have a lot of agreement about what our problems are.
All right. Well, this has been really, really nice to get this view behind the polling. And again, I think people are realizing how familiar they are with you, even though they don't know you personally until today. And so I'd really like to thank you, and I hope we can have you back, down the line as the slate of issues evolves. So thank you so much. And I'm going to just
Wonderful.
thank you so much. I'm going to give a little preview of what is coming up. We have Dr. Toby Cosgrove next week, the former CEO and current executive director of the Cleveland Clinic, one of the most storied chief executives in healthcare of the last many decades. And that's next week. And Christina Farr, health tech investor at Omer's Ventures, former technology and health reporter for CNBC. And she's going to talk about, among other things, the overlap between what she needed to suss out as a reporter and what she needs to suss out as a venture capitalist. You can find us at chip.org/events to register. And you can also reach us at chip.org. And we're very eager to hear from folks and hear about suggested speakers, possible collaborations, training opportunities. Thank you very much.